ACE Podcast.
Hello and welcome to Vaguely Accurate, the science show we meet, learn and discuss with early career scientists. I'm sure you've noticed already, our audio quality is dramatically improved. We have invested in a couple of new microphones to help deliver the content from the show. Thank you for bearing with us for the previous episodes. Very aware some of the audio quality from previous episodes has been a little sketchy. So this week we have Mariette on the show.
Hi.
How are you?
Good, thank you.
Mariette is a friend of mine from here. However, she's Dutch and she's spent the past, was it a year?
Yeah, 1 year.
Yeah, 1 year in Amsterdam, which is amazing. We had the chance to come out and meet you, which was absolutely beautiful.
It's very fun.
Yeah.
Yes.
So do you mind introducing yourself, telling us a little bit about what you study and also what got you into it?
Yeah, sure. So my first degree, I did physiotherapy at Curtin University, and I worked as a physiotherapist for a couple of years in Australia. And then I decided to move over to Amsterdam to do my master's in health policy and management at the Vrije Universiteit, which is sort of in the south of Amsterdam. So I did my degree as a Dutch student over there. So most of the course was in English, but a couple of units in Dutch, which was good for my language skills. So I got into health policy because I wanted to look at sort of bigger picture health, because as a physio, you're looking at patients individually in the clinic. And yeah, often you're noticing different things within our healthcare system, what we are and are not able to do, just depending on the way the system is structured. So for example, in Australia, we have the private and public systems side by side. And in that sense, it was really cool to do my master's in the Netherlands, because over there, one system is suiting everybody. It's a lot more similar to the UK beverage style system, where they have the NHS and everything is public. Although now in the Netherlands, they're starting to get some reform, introduce health insurance, but it's still sort of one system rather than a distinction between public and private, which is really interesting.
So what made you go over to the Netherlands to do your research, considering the systems or the health systems that you are looking into are so different compared to Australia here in the Netherlands? Were you going over for more just of a comparative kind of study yourself, or was it, I suppose, just a cultural change? Like, what was the benefit for you to change country to do your research?
A lot of factors. So definitely from a research point of view, it was really cool to study in a different healthcare system and sort of see what works for them and how it's different to Australia. But also a lot of personal reasons, because my family live in the Netherlands. I've always wanted to see what it was like over there. And I did find out very quickly how much it rains over there. But yeah, from a cultural point of view, it was really cool just living on the other side of the world and having that base in Europe to be able to travel around.
What did you think of the Netherlands? Like, when I visited, I thought it was absolutely beautiful. And everyone cycles. Yeah. It seems healthy.
But it's definitely a very forward-thinking country. So, for example, they've had euthanasia for a number of years there, whereas that's something we're only starting to discuss in Australia at the moment. Also, things like gay marriage and the legalisation of cannabis. It's a very different ball game over there compared to what we have going on here in Australia.
Do you mind telling us what got you into healthcare? What got you into caring for people, I suppose, whether it be on an individual scale or on a broader spectrum?
Well, I think I've always come at it more from a movement point of view, because I always liked going to the gym and, sort of looking at technique. And I was a runner myself, so I had a lot of foot injuries from my long distance running. And so that kind of exposed me to physiotherapy and different patterns of movement and what that can do for the body. And so in that sense, I sort of got into the physiotherapy. And then from there, when you're working in healthcare, you're just really exposed to the health insurance that we have here. What does it cover? What does it not cover? I also worked in hospital for a year, which was really interesting because in private hospital, you still have a lot of fee gaps with if you're going in for a hip replacement or something, you're still going to have to pay extra for the consultant, for the anaesthetist, for the physio afterwards. So I was really interested in looking at sort of the payment and bigger scale of healthcare and a physio's role within that system.
So I understand that as well. I got stung when I got my wisdom teeth removed. Like, the anaesthetist, the hospital, everything, it really adds up when you kind of just think, half it's subsidised. And so half it's probably not even touched.
And coming from the UK, that would have been a real shock to you, because over there with the NHS, like, you just get everything. You
just rock up and you're just like, I need this broken, fixed, back together, please.
Yeah.
And just like, sure, here's a new arm.
But it's really interesting with a system like the NHS that if, say, as a policy maker, if you have £10,000 to spend, you have to make a lot of choices. Are you going to spend that £10,000 on a really expensive bone cancer treatment that might be able to save one life, or would you spend that £10,000 on flu vaccinations that could help maybe 20 or 30,000 people and prevent them getting sick and their hospitalisation costs for a whole season? So there's a lot of decision making, and I find these discussions really interesting.
I think it was Hurricane Katrina, and they had some hospitals making ethics decisions on a more immediate scale, similar to that.
Yeah.
Like, they were obviously trapped in a hospital and they only had limited supply of resources, and from that, I think it's extended out that is quite a highly debated topic in healthcare itself. What do you do if you are in a scenario where you can only, choose who's play God, I suppose, in that. Choose who's going to live, choose who's not going to live with limited resources.
Yeah, and it's hard, but it's a reality of life, because especially money-wise, our healthcare system, we don't have limitless money, so we've got to sort of draw the line somewhere with, okay, what are we going to pay for, and where are we going to draw the line?
Yeah. So, taking a segue into your research, could you tell us what is the title of it?
Yeah, sure. So the title of my article was Predictive Factors of High Societal Costs Among Chronic Low Back Pain Patients.
Okay.
So I think I chose a back pain related topic because, coming from physiotherapy, it was quite relevant for me because we had sort of a list of topics that were available for us as master's students to work on. And I did sort of want to tie it back to my physio, but then also explore that economic cost side of treatment.
Yep.
So that's really interesting, because the economic side of things is not necessarily overlooked by the individual, but as individuals, we don't often take into account or can take for granted the financial benefits we are given by our country or the government or a governing body. What was the methodology, or what approach did you take towards this study?
So I made 3 prediction models and bootstrapped them all, and then validated them as well. So the reason I did 3 prediction models is because I used a dichotomous outcome, which was high societal costs, yes or no. And high societal costs, where do we define that? Is that the top 90th percentile, the top the top 10th percentile, the top 20th percentile, or the top 25th. So those were the 3 prediction models that I made, just to have a different threshold for high societal costs and see if that would make a change in which predictive factors we picked up.
To summarise, I suppose, you're looking at, as an individual or as a society, you have a group of individuals with back pain.
Yeah. And
that back pain is on varying scales depending on an individual, and that scale is going to depend on their health, their health state and how they live their lifestyle state. And when you're saying you're looking at the percentile or the societal costs, is that if the healthcare system is going to cover the costs of this individual, how much is it going to cost over the lifespan of that injury? Is that what you're referring to?
So it's more like, can we look at factors that flag these patients as being high-cost outcomes? So of all the patients with back pain, maybe if they have a high, for example, Oswestry score, which is a questionnaire that we as physios, and I'm not sure if chiros use it too, just to sort of screen back pain patients. Mm-hmm. And if they have a high Oswestry score, maybe that means that their overall treatment will bear a higher cost to society. And if we flag them early on, maybe we can modify our intervention to target this patient and reduce the cost outcomes from a preventative point of view.
What are the societal costs that you refer to? Are they costs from the taxpayer or an individual or the government body itself?
So societal costs are the net effects to society. So it kind of includes all of that. And when you're doing a economic study, sort of like mine, you want to look at the net effects to society. So that's why you take all perspectives into consideration. So what we did for my study was look at societal costs using 3 monthly retrospective cost questionnaires, and we administered them at 3, 6, 9 and 12 months. So it was in total a 1-year follow-up period. And the self-completed cost questionnaires looked at informal care, unpaid productivity, employment absenteeism, and also healthcare utilisation. So by categorising costs as I mentioned, all of the stakeholders are considered, and any cost shifting can only occur between those groups. So that's why you see the net effect to society. And one of the limitations, which we'll get into later, is that while we did include absenteeism costs, it's really important in these sort of studies to look at presenteeism as well, because someone might be going to work with back pain and if they're sitting there in pain, they're not going to be as productive as somebody who's just going to work healthy and fit.
Do you mind just defining absenteeism and preteeism, was that?
Presenteeism. Yeah, so absenteeism is, if you're having back pain today and you call up work and you say, okay, I'm not going to come in, mm-hmm. Whereas presenteeism, you go into work but your productivity is less because you're injured or sick in some way.
So does your study take into account like workers' compensation and those kind of societal costs as well?
I'm not sure if we actually looked at workers' compensation, but we did look at employment absenteeism and the cost that bears to the employer, because they still have to pay for that person as though they're at work.
Yeah. So before moving on, I'd like to summarise the 4 economic factors or the parameters of economy that you've just mentioned. You've said that you're looking into the informal care, so how much help someone or an individual is receiving from friends or family that's usually unpaid. Unpaid productivity, I suppose, is looking into how productive they are at home. Are they still doing their own shopping? Are they still doing everything they would be, or how limited has this back pain caused their daily activities? Employment absenteeism is whether they're turning up to work or not, and the societal costs of that to a company. And the healthcare utilisation, looking at the frequency of which an individual visits a health practitioner in relation to their back pain. Let's move on to the results. Can you tell us what have you found?
Yeah, sure. So I did 2 parts to my analysis. I did a univariate analysis first. So I put all of these different pieces of data into a model and first looked, is there an association with high cost outcomes? So we had a lot of demographic data like gender, age, BMI, your education level, are you a smoker? What sort of back pain do you have? For example, is it facet joint? Is it a disc? Is it a combination? We also looked at ethnicity. So are you Dutch, yes or no? Because different ethnicities, so for example, we know that the Dutch are very tall compared to the rest of the world. Mm-hmm. So maybe that predisposes them to high cost outcomes or different outcomes to the rest of the world.
Yep.
We also looked at the duration of the episode of back pain. Have have you had previous episodes of back pain? And then we looked at a bunch of questionnaires. So the CEQ, Client Expectations Questionnaire, the Oswestry Disability Index, the NRS pain score, and we also looked at the MPI, which is the multi-dimensional pain inventory. We also looked at living situation. For example, do you live by yourself? Do you have children that are depending on you? Do you have a spouse that is depending on you for care? All those kind of things. So from the univariate analysis...
That's a lot to go on. There are a lot of variables going on.
A lot of variables, yeah. It's not perfect, which we'll discuss later, but you want to have as many potential predictors as you can to be really thorough with your study.
See, there's a lot of statistics going on in yours.
There's a lot, yeah.
Is that what, I suppose a lot of the science behind this, is it mostly all statistical basis? Like you go out and collect your own data and then you come back and do a lot of stats, or did you find that you're using secondary data a lot of the time?
So I was using secondary data from a study called the MINT study, and that was conducted by a PhD student at the VU called Esther Mars. And so she was looking at back pain patients and minimal intervention treatment. So I used all of her cost data and sort of the baseline demographics as well.
Yep.
And that made up the database for my analysis.
I think what we all know, what did you find? Taking into all those parameters that you had, did you find that there were higher societal costs for people, I suppose, that did smoke, which is what you would predict, or had previous experiences of back pain? Or even, I'm curious, was there an ethnicity difference?
No, actually, a lot of the ones that I thought would be significant came out as, a lot of them didn't make it through the multivariable analysis. So that was very interesting to me, because you would think maybe a smoker causes higher costs, but in terms of back pain, we didn't actually find that in our study. So using the top 10th percentile of high cost outcomes, the three that we found were significant were patients with a higher Oswestry Disability Index score. So that's basically looking at their functional status. So somebody who's more limited doing daily tasks by their back pain was causing a higher cost to society. The other one was the EQ5D or EuroQual, which measures health-related quality of life. So that's looking at somebody who is very limited by their back pain in terms of quality of life. So maybe this person is unable to participate in social functions, or unable to fulfill their role as a parent or as a child because they're limited by their back pain. And the other one was the MPI score. That was significant. So that's looking at chronic pain experiences. So all of our patients had chronic back pain, and it's just sort of, maybe some of them have had a more positive experience than other people, and that could relate to their treatment experiences, how they perceive pain, how they deal with pain, all of those kind of things.
Did you take into account mental health status? Like, I suppose their state of mental health is going to play an impact and significance on their societal costs and how they handle their back pain.
Absolutely, that's a very relevant point, because pain is perceived in the brain, and so often I think patients with depression, sort of anxiety, we call them yellow flags, because that can lead to longer pain, more likelihood that they have chronic pain. But unfortunately in our study we didn't specifically ask clients, do you have a mental health condition?
Okay, so I suppose that would come down as one of the limitations
yes.
of the study itself.
Yeah.
Before we move into limitations, what is the impact and significance of your work? What are the practical applications that these can be utilised by the health department?
Yeah, there are a few questions in there. So
there is.
I'll start with the clinical findings. So basically, if we give back pain patients these questionnaires early on, maybe we could use some sort of preventative treatment modification or get them seen more by multidisciplinary teams to address some of these factors. So, for example, someone with a high Oswestry Disability Index score, so they're having problems with functional tasks, maybe they need an OT review to help them to adjust with their back pain in that transition period while they're getting some physio treatment or other treatment to help solve their back pain. And also looking at, for example, chronic pain experiences. Maybe if we flag these patients early on, we can target their treatment a little bit more specifically and hopefully prevent the high-cost outcomes later down the track.
Awesome. Is your research itself able to be used globally, or is it going to be more relevant to the Dutch?
So it is more relevant to the Dutch just because of the way the healthcare system is structured. And we used a population of mainly females from the Netherlands. So all the cost data, so in terms of measuring how much a physio appointment costs, how much absenteeism costs are rated at, that was all using Dutch economic data. So you would have to adjust that to whichever country you're trying to use this information in. But I definitely think that low back pain is a global problem, and in that sense, we've got the Oswestry Disability Index here in Australia and the MPI as well. So those are two questionnaires we could definitely be using here in Australia as well.
So this study, despite being relevant, it can also be replicated in Australia using the exact methodology, I suppose.
Yeah. So some of the strengths of our study is that we had such a large population size because I used data from the MINT study. They had a really big sample size, which was great. So we had a lot more power, and that improved the sensitivity to weak predictive factors. So that was good. And also for missing cost data, because it was self-completed questionnaires, particularly towards the 9 and 12 month follow-up periods, some patients weren't filling out that data. So what we did is, at the time after we cleaned the data, we used multiple imputation to keep that large population size. And in terms of imputing missing data, multiple imputation is the most accurate technique that you can use. And also the fact that we bootstrapped with 250 replications improved the generalizability and the robustness of our findings. So they were good things.
Do you mind if I ask, what is bootstrapping? It's something you've mentioned a couple of times, and I've been trying to think.
So we used a different program. So the main analysis was done using Starter, and then we used this other statistical program called R to do the bootstrapping. So what it means is that when you build a prediction model, you have a population and you run them through the model, and that's your outcome. So then with bootstrapping, you're doing 250 replications to see where the outliers are. And then sort of, in that sense, you're generalizing your results. So you're using a lot of different potential populations and running them through the model just to see what other outcomes you could get.
So it's almost making subcategories of all the large data set you have and all the samples.
Yeah, sort of. So some of the limitations, I mentioned earlier that we didn't include presenteeism costs. And that can be a real problem because, when someone goes to work and they have low back pain and they're not performing as they normally would, the whole company will potentially lose money because that worker has a lower productivity than they normally do. So that was something that if I was to collect this data again, maybe I would have included presenteeism costs. Also, the problem using the self-completed cost questionnaires, as I mentioned before, towards the 6, 9 and 12 month period, patients were not filling out those questionnaires and returning them to us, which was a bit of a problem, but at the same time, they really suggest to use self-completed cost questionnaires and to administer them at 3 month periods, because if you're trying to think of money that you spent 6 or 9 months ago, you're not going to remember that.
So it sounds like it's pretty comprehensive as far as a few limitations are. Like you didn't take into account mental health, and you have to kind of extrapolate a few extra data points from where people decide to get lazy or kind of drop off the radar. So apart from that, it seems pretty comprehensive, and the methodology and the technique can be applied and can be used for most systems in different countries for their models.
Yeah.
Awesome. So what is next for you, I suppose? What are you planning to do now, seeing that you've this endeavours and you're back in Australia?
Yeah, so I've got a job now with the WA Health Department as a graduate project/policy officer. So I'm hoping to use my skills to move into more of a policy advisor role later down the track. So as I mentioned before, making those decisions about where is our health budget going to go on a state level, and also within different departments of the health department itself, working on some of those projects.
Do you happen to have any idea currently where you think the health budget should go? Do you happen to have an idea of where too much money has been spent currently?
So I think with WA, we're always going to have a lot of challenges like rural and remote health, because we're such a large area, and for example, some of the Indigenous communities are quite difficult to reach. So I think we should definitely continue spending money on providing services to remote populations within WA, and we're always having to look at cultural differences when we treat these populations as well. Also within Perth, I think at the moment we've got a lot of new projects, for example, the new children's hospital being built, Fiona Stanley recently opened, so a lot of our funding has gone to providing new services, and I think now we need to get our staffing a little bit more on par, because I think Royal Perth recently had their burns unit upgraded and trauma as well, but now trauma has gone to Fiona Stanley, so our demand for healthcare is only increasing. So maybe down the track we need to look at, rather than building new places, just creating more jobs for staff and trying to reopen some of the facilities that we already have, or improve current services that we have.
Yeah, that makes sense. So it's almost like you've started a second career now. Like you've done physiotherapy for a couple of years, and you're just like, yep, tick that one off, moving on, sticking with the current trend of I don't know what generation you'd call it, but everyone seems to like move jobs every 5 years.
Well, they say the average career span of a physio is only 7 years now, and I found that out after I graduated, which was a bit surprising after a 4-year degree. That's not a lot, especially when you put so much effort into doing it. Do they usually restrict to themselves to still health fields? Do most physios kind of jump off to something that you're currently doing? Yeah, I'm not entirely sure. I think a lot of them tend to go into more sort of managerial or case managing sort of jobs. Going to work for insurance companies as well is definitely a line that people go down. But yeah, I think it varies from person to person.
I suppose we'll probably call it there, but thank you very much for coming on the show. Really appreciate having you.
Me.
It's all right. There was a few blunders in there from my part and yours, but we'll see what we can do with those.
And that's it from us today. Thank you very much for joining us, everyone. I hope that you've learned something new. The show is taking a different approach today, looking at health and health policy. So I hope you learned something and expanded what you already knew. If you happen to have any comments or feedback about the show, feel free to get in contact with us via Twitter, Facebook, or you could just send us an email at vaguecomments@gmail.com. Likewise, if you happen to have anyone in mind, or you yourself may be interested to feature on the show, talk about your research and get some discussions going about it, feel free to contact us at vaguecomments@gmail.com, or fill out a contact page on our website. On that, check out the website. We've got some good articles up there. We also share videos and everything from everyone else. That's www.vaguelyaccurate.com. And yeah, I suppose that's it from us today. See you soon. Bye.